Over to you, sir, please.
Thank you, MSN, for organizing this meeting, highlighting the role of the most important innovation in recent times on antiplatelet therapy, particularly a parenteral agent, which we have been searching for. And as we all very well know, the biggest enemy to the interventional cardiologist in the cath lab is thrombus in the coronary artery. So we always want to fight this thrombus, treat thrombus, prevent thrombus, and all thrombus-related complications. And as we all know, the more aggressive you are in preventing thrombus, the inevitable problem that you have to face is excess bleeding. So you have to balance out this risk, the benefits of being antithrombotic at the same time, not increasing the bleeding risk to prohibitive levels. So we have always been searching for this molecule, for such a molecule, and we have never ever achieved, because we all know the more an agent is anti-ischemic, there is always a risk of bleeding. And as recently we did a case in our cath lab a few days ago, and that was an elderly lady, and that lady had an occluded circumflex with an inferior posterior MI with mitral regurgitation, who presented late to the cath lab. Then we had difficulty in crossing this vessel. She had triple vessel disease. Somehow managed to wire this vessel, and we did a nice pre-dilatation. There was significant thrombus burden. We aspirated the thrombus, and there was no flow in the vessel, despite all the intracoronary medications that we have in the shelf, including adenosine, adrenaline, all kinds of agents. In other words, thrombus is the real enemy in the cath lab, and it's a real challenge to overcome thrombotic issues in the cath lab, particularly during PCI. And one of the problems in doing a PCA, especially primary intervention in the context of an ST elevation myocardial infarction, is we have to be very swift in the cath lab. The patient comes to the casualty, you load the patient with antiplatelets, rush the patient to the cath lab. In the way, some patients vomit, there may be reduced bioavailability. There is a delay in the action of these orally administered antiplatelet drugs, like, for example, in today's time, ticagrelor, in yesterday's time, agents like clopidogrel, for instance. So there's always this issue of inadequacy of platelet suppression in emergent interventions like primary angioplasty in the context of myocardial infarction. And we do come across thrombotic issues. In the past, we used to give glycoprotein antagonists to solve this problem, but we all know that it has its limitations, particularly with increased risk of bleeding complications. So in this context, we now have this new molecule called Cangrelor, which is parenteral. It's very exciting because the onset of action is very quick. Within 2 minutes, the action starts. And it is a reversible action. And at the end of a bolus followed by an infusion, if you stop this drug, the offset is also pretty rapid. So the onset is very quick. The offset is rapid. By the time the orally given drug is expected to take over its action. So that is the excitement about this molecule. And this molecule has earlier been compared with clopidogrel in various trials called the Champion series of trials. And more recently, we have also an evidence in comparison with ticagrelor, because that is the most commonly used second antiplatelet in addition to ecosprin in today's time and age. So we have two exciting talks to follow. That is one by Dr. Jabir, who will give the clinical evidence in the form of trial data, where we stand, the utility, the indications, the guidelines with this new exciting molecule, to be followed by Dr. Deepak Davidson, my good friend, who will share some clinical experience with this molecule. And before I pass on to Jabir and Deepak, I will invite my co-moderator chairperson, Dr. Jimmy George, my very good friend. And as the introductory slide very clearly said, he has a lot of experience in very complex interventions like total occlusion, revascularization, etc. I'm sure he will also be looking at a dream molecule which will be extremely antithrombotic without increasing the risk of bleeding. And I invite Dr. Jimmy to give some opening comments and set the ball rolling for the talk by Dr. Jabir. Over to you, Dr. Jimmy.
Thank you, Natarajan, sir. Actually, sir, you almost discussed that part of Cangrelor as an intravenous drug. But I would like to add on, majority of ACS situations also comes with almost around 10% of patients going in shock or ventilated patients, therefore which even giving these medications orally may not be having a high bioavailability. So these are situations where when you expect a high thrombus burden and patient cannot be given an oral drug, an intravenous drug definitely has its own action. Whether the GP inhibitors were taking this role or whether now the Cangrelor takes on its place is something to be seen in the future. At the same time, we need to have situations where even in NS elevation MI or STEMI cases, where you have got high risk ACS situations where you have interprocelus disease, you need an urgent bypass surgery. So these are situations where surgeons are not that much of interest in stopping these medications in a few hours. They may take at least 2 or 3 days in taking the surgeon for a surgical procedure. So whether this IV drug, which has got an high onset of action at the same time, a very high offset of action, would take in the surgeon's interest or surgeon's effect is something to be seen in the future now. So like what Natarajan was saying now, so we'll have a good discussion on whether this IV drug would be really beneficial, and followed by adding on the potent prasugrel or ticagrelor in the future for these medications will have more effect in reducing the peri-procedural MI or stent thrombosis, which are supposed to be more seen when you have a complex case and long stents to be done. So I think we will have the first talk and first discussion. I think Jabir is going to have the first talk on Cangrelor. Over to you, sir.
Thank you, Jimmy. Thank you, Nataraj. So I think I'm audible, isn't it?
Very loud and clear as usual.
All right. Okay. So it's I must put it as Cangrelor revisited, because this molecule was introduced with a champion group of trials, as Dr. Nataraj was telling, in 2012, 2013. Then it remained in I think it is mere oblivion, and just that its trial name says Phoenix. It's now getting I think it's in the line of resurrection from its own ashes. I don't know, because it's quite unusual that after 9 years or 10 years a drug is coming back. So when Nataraj says platelets plays a crucial role in the formation of thrombus following a plaque rupture, or it could be a plaque erosion. So the platelet, various phases of platelet incorporation, or its role in the formation of thrombus, the adhesion, activation, and aggregation, and development of thrombus, which may be a subtotal occlusion of the coronaries leading to a STEMI, or a total occlusion of the coronaries leading to a STEMI. Whatever it is, whether it is a STEMI or STEMI, dual antiplatelet therapy has been found to be the cornerstone of therapy for percutaneous coronary intervention following an acute coronary syndrome, especially following a drug-eluting stent. And now drug-eluting stent is the way forward. So dual antiplatelet therapy is the current cornerstone of therapy following an intervention in an acute coronary syndrome. For that matter, for an intervention following a stable or a chronic coronary syndrome, also dual antiplatelet therapy, maybe the duration differs, but it's in early part following the intervention, dual antiplatelet therapy is the standard, which is a P2 vital inhibitor plus aspirin. So we have the two groups of P2 vital inhibitors, the prodrugs, which are prasugrel and clopidogrel, which has to be converted into its active metabolite. Clopidogrel from the intestinal absorption, from it has to be converted to go through the hepatic CYP metabolism, a two-step oxidation into its active metabolite. Prasugrel after the intestinal absorption, a single-step oxidation mechanism by which it is converted into active metabolites. And the active metabolites of clopidogrel and prasugrel are of having short half-life. And these molecules, they occupy the position where the ADP has to bind. So when they occupy the ADP receptor position, so the ADP mediated activity of the platelets is inhibited for the lifetime of the platelet for prasugrel and clopidogrel. Ticagrelor, it is a non-thionopyridine. Cangrelor is also non-thionopyridine. Both are reversible ADP receptor inhibitor. So ticagrelor binds to some other site of the ADP receptor, not the site where the prasugrel and the clopidogrel binds. So Cangrelor is a direct platelet P2 vital receptor antagonist. Half-life, as Nataraj was also mentioning, very short half-life, 3 to 6 minutes. And the offset, once you stop the infusion, the complete antiplatelet effect goes off in 1 hour time. And one more important thing, its metabolism is not dependent upon the renal or hepatic function, which is important because one molecule which is going to compete with this thing is the glycoprotein GB2B3A receptor inhibitor, which has with problems in renal dysfunction and hepatic dysfunction. So these are the most important differences between these molecules. Ticagrelor and Cangrelor are reversible, very short half-life for the Cangrelor when compared to prasugrel and clopidogrel. But you can see the active metabolite of clopidogrel, its half-life is only 30 minutes. For prasugrel also, it is 30 to 60 minutes. But the long action is because of its permanent or permanent inhibition of the ADP receptors of the platelet. So all these things bind to the ADP sites. All the other three drugs, clopidogrel, prasugrel, ticagrelor are oral, and Cangrelor is the only intravenous antiplatelet P2 vital inhibitor available. Intravenous aspirin is available in Europe and they uses it. And the way we administer is a bolus plus infusion, and it quickly acts. The action comes in 2 minutes, and the approved setting of use in PCI in patients with or without ACS. We have clopidogrel, we have prasugrel, we have ticagrelor. They are all potent agents. The prasugrel has advantage over clopidogrel, though there are certain situations, subgroup of patients where it can be dangerous due to the excessive bleeding risk. And but ticagrelor is also much better than clopidogrel as per the randomized control data available, especially from the large trial of the Plato. And why these drugs are more effective? Because we consider them to act quite early. Their inhibition of platelet activity comes quite soon, and clopidogrel acts quite because of the two-step oxidation conversion. It acts quite late, or it's a delayed action. It may take 6 hours to 24 hours for the antiplatelet action of the clopidogrel to come if we are giving only a 300 milligram. If you give a 600 milligram loading dose, it may come in 6 hours. But this study by the Greek investigator in patients with STEMI, they found that you can see ticagrelor as well as prasugrel, the supposed inhibition of platelet activity in 2 hours. We thought, we think that this comes quite early, but you can see at 2 hours, at 1 hour, there is no significant inhibition of platelet activity when you look at the platelet reactivity units. At 2 hours also, only 50%. And 6 hours, it's a decent effect, almost 70 to 80% of inhibition of platelet activity. The platelet reactivity unit is significantly lower than 200. And by day 5, it's persistent. For both are equal. The prasugrel as well as ticagrelor are equal. So though we believe that the action comes quite early, and in acute coronary syndrome, we give a loading dose and we think it acts quite much earlier than clopidogrel. But in STEMI patients, this has shown that the action comes usually after 2 hours. And in the rapid primary PTCA study, ticagrelor versus prasugrel in STEMI, you can see that at 2 hours, it's borderline 250 to 200, almost 250 to 200 is the platelet reactivity units. So in reality, when it is a STEMI, these drugs are not acting quite early. It may take 2 hours, or it may take even 4 to 6 hours for its significant inhibition of platelet activity has to come. And so at the time of a primary PCI, when we desire for the maximum inhibition of platelet activity, in fact, these drugs are not covering with an excellent antiplatelet activity. Maybe due to different reasons. Dr. Jimmy was mentioning about the patients who are intubated, patients in cardiogenic shock, patients who are vomiting, patients who were given morphine to cover the pain, to control the pain. These are patients in whom, though we are giving the oral loading dose of the drug, it remains in the intestine. Either it's not absorbed, the intestinal motility is not there, it may remain in the stomach, or it may be vomited out, or we may not be able to give an oral drug. There are certain situations where we are not able to administer oral drugs. So the drug has to reach the circulation to exert its effect. And in the setting of STEMI or acute coronary syndrome, there are situations when an oral drug is not sufficient, or oral drug cannot exert its immediate effect because of various problems. So we may require an intravenous drug. So there are gaps in platelet inhibition. So in order to fill this gap, what can we do? One is early administration in a patient, if it is a drug with delayed onset of action like clopidogrel, very high loading dose. We have tried even 900 milligram of the loading doses. Or crushing the tablet. You crush the tablet and give Ticagrelor, crushed tablet, the Mojito trial and all is there. Prasugrel also, there are trials where they tried crushed Prasugrel tablets. Or you use intravenous therapies like glycoprotein 2B3 receptor antagonist or Ticagrelor. So the champion group of trials were the initial studies where Cangrelor was tried. The champion Phoenix, the champion PCI, and the champion platform. And we have a meta-analysis of all these three trials together. Champion Phoenix, it was Cangrelor bolus, then infusion, up to almost 2 hours, followed by clopidogrel loading dose in the active arm, versus clopidogrel 600 or 300 milligram oral dose. That was the study. That was the study protocol. Then the champion PCI were Cangrelor bolus, then infusion, but at the same time, a clopidogrel loading dose was also given later on after discontinuation clopidogrel. And Cangrelor bolus, then infusion, plus clopidogrel after 30 minutes in the champion platform. If you look at the champion trials pooled analysis, the combined endpoint of death, MI, ischemia-driven revascularization of stent thrombosis within 48 hours, with 4.7% in clopidogrel, with a 3.8% in Cangrelor, which was statistically significant. And this benefit was seen in all the subgroup of patients where this was tried in stable coronary artery disease, non-ST elevation ACS, as well as in STEMI. And the bleeding was not significantly higher, especially life-threatening bleeding was not significantly higher in the Cangrelor group. And the propensity matched analysis comparing Cangrelor alone versus clopidogrel plus glycoprotein 2B3A receptor inhibitor in the champion trials. You can see the endpoint of the composite primary endpoint, stent thrombosis, gusto severe bleed, need for blood transfusion. All these things were lower, may not be statistically quite significant, but numerically less in the Cangrelor alone group when compared to the clopidogrel and glycoprotein 2B3 receptor antagonist. So Cangrelor alone was associated with a similar ischemic risk and lower risk adjusted major bleeding when compared to clopidogrel plus glycoprotein 2B3 receptor antagonist. The champion Phoenix, this is the study which has a protocol which we would like to use. Before loading with the oral P2 vital inhibitor, start the patient on Cangrelor. Then once the Cangrelor infusion is over in 2 hours time, put the patient on clopidogrel. Sometimes we may continue the Cangrelor infusion for another 2 hours or so for the clopidogrel effects to come. What they found is the primary efficacy endpoint, death, MI, ischemia-related or ischemia-driven revascularization, stent thrombosis, statistically significant difference between Cangrelor and clopidogrel. Stent thrombosis, there is a significant difference. Intraprocedural stent thrombosis, myocardial infarction, there is a difference at the same, and you can see on the left-hand side, the intraprocedural stent thrombosis in all subgroup of patients, stable angina, non-ST elevation MI, and STEMI, there was a different, but of course, borderline statistical significance. This is the study which was published 2-3 days ago in Circulation Intervention. Ischemic events, when does it occur? In the champion Phoenix, a sub-analysis, they found ischemic events occur during the early phase, within the first 2 hours. You can see in the graph, it is in the first 2 hours, 5.4% in the clopidogrel arm and 4.1% in the Cangrelor arm. And the difference, you can see the separation of the graphs. The separation is graph only up to 2 hours. Afterwards, it's almost similar. One graph is falling on the other. The Kaplan-Meier curve, there is no difference. It is 0.65% and then 0.56% up to 48 hours. So the acute events occurs during the early phase. This is quite logical. During that time, our oral drugs are not giving protection. And when you are using an intravenous drug with a short duration, very fast onset of action, it covers and prevents the event rates. So the reductions in the ischemic events and overall efficacy seen with Cangrelor in the champion Phoenix trial occurs quite early and during the period of time in which patients were being actively treated with Cangrelor. This evidence supports the importance of a potent platelet inhibition during PCI. And this is all with the clopidogrel. So the newer agents, Prasugrel and Ticagrelor, is there any difference? So this is the CANDIC study, platelet inhibition with Cangrelor and crushed Ticagrelor. So early absorption, better absorption in patients with ST elevation myocardial infarction undergoing primary percutaneous coronary intervention. So crushed ticagrelor plus placebo IV or crushed ticagrelor 180 milligram with Cangrelor IV. And you can see immediately within 5 minutes, there's a significant fall in the platelet reactivity units up to 50 units or 60 units. At the same time, the crushed ticagrelor, it's still above 200 and it fell down below 200 only after 1 hour post bolus, and significant fall with a statistical significance between the two curves. You can see a 2 hours post bolus, and by 2 hours post infusion, both have similar action. So there is significant early platelet inhibition with Cangrelor that is not matched by a crushed use of crushed tablets of ticagrelor. In the pharmacodynamic assessment measured by Verify now, following administration of Cangrelor versus placebo, 5 minutes. 5 minutes is the time taken for significant fall in the platelet reactivity units. So PRU level at 30 minutes were significantly lower with Cangrelor compared with the placebo. And this part, the later part, which shows that that is one thing that we are all worried about, a drug-drug interaction when clopidogrel or prasugrel is given along with Cangrelor. When you give Cangrelor and if you administer simultaneously clopidogrel, there is a drug-to-drug interaction. I'll come to it. That drug-to-drug interaction is less likely to be there with ticagrelor. So ticagrelor plus Cangrelor seems to be the best therapy available right now for an early and a potent action. And individual values of platelet reactivity measured by Verify now following administration of Cangrelor versus placebo, you can see almost 70%, 5 minutes. At 5 minutes, it is less than 200. But at 30 minutes, you can see almost 70% of the ticagrelor group is they still have a platelet reactivity of more than 200 units. So end of PCI at 41 minutes, high platelet reactivity present in almost half the patients at the end of the PCI and 1/3 of patients at the end of the placebo infusion in the placebo arm, numerically higher bailout and 1 acute stent thrombosis in the placebo arm. So you can see half of the patients at the end of the PCI and 1/3 of the patients at the end of the placebo infusion. So significant number of patients had a high platelet reactivity. And what are the difference between Cangrelor versus glycoprotein 2B3 receptor antagonists? Fast onset of action, both. Potent platelet inhibition, no doubt, both are potent platelet inhibitors. Problem, offset of action, even the smaller molecules like tyrosine takes 4 hours. Cangrelor offset of action in 1 hour. Kidney friendly, GPI not kidney friendly, Cangrelor kidney friendly, liver friendly. And the natural bridge, it is a P2 vital inhibitor. So the natural bridge for a targeted inhibition is Cangrelor, not glycoprotein inhibitor. So what are the benefits of Cangrelor? It decreases stent thrombosis, an MI in all undergoing PCI. It's highly useful in all those who have administration or absorption problems with oral medications. So if the patients are not put on an oral agent and you do a coronary angiogram on Cangrelor, and if the anatomy seems to be not suitable for a PCI and he requires an emergency or an early CABG, there are no threats in the form of a potent antiplatelet on board. That is another advantage. So what happens in the Cangrelor to thienopyridine transition? You can see these are the receptors, the P2 vital receptors to which the Cangrelor is bound. When the Cangrelor is potent, when it is bound to all these receptors, and you give a thienopyridine, the thienopyridine cannot find the receptors empty to bind. So when you give thienopyridine along with Cangrelor, it cannot bind to the receptors which is already occupied by the Cangrelor. The problem with prasugrel and clopidogrel here, the active metabolites, the half-life is quite short. So you give at the 0 hour Cangrelor and thienopyridine together. After 1 hour, Cangrelor acts, thienopyridine active metabolites disappear from the bloodstream. The effect is not there. That's why it is considered that we should not simultaneously administer Cangrelor and thienopyridine together. So if you use Cangrelor, thienopyridine to be given once the infusion is completed. So active metabolites of thienopyridines are very unstable with a rapid clearance from systemic circulation. They will not bind to the P2 vital receptor if occupied, and thus should be administered after discontinuation of Cangrelor infusion. Prasugrel can be administered 30 minutes prior to discontinuation of Cangrelor infusion. And if it is ticagrelor, the beauty of ticagrelor is that the major metabolite can also bind to P2 vital receptor. The half-life is 10 to 12 hours. So these active metabolites will be available there for binding once the Cangrelor has been cleared. Therefore, ticagrelor can be administered before, during, or after Cangrelor infusion. So if you are using an antiplatelet agent early with Cangrelor infusion, ticagrelor should be the preferred agent. So transition from intravenous to oral agents, P2 vital inhibitors, Cangrelor 30 microgram per kilogram bolus followed by 4 microgram per kilogram per minute infusion. Clopidogrel 600 milligram after discontinuation of Cangrelor. Prasugrel within half an hour of discontinuation of Cangrelor. You can give it half an hour prior to the discontinuation. Ticagrelor immediately after discontinuation, or you can even at the beginning. And when you transit from Cangrelor to an oral agent, always use a loading dose. Ticagrelor can be administered before, during, or immediately after Cangrelor infusion, although earlier administration should be considered. And another important or potential use of Cangrelor, those people who are undergoing surgery after a coronary stent implantation where you need a bridging agent. Antiplatelet therapy with Cangrelor in patients undergoing surgery after coronary stent implantation, a real-world bridging protocol experience. In those patients who are undergoing for various surgeries, following a those who are on dual antiplatelet therapy following stent implantation. Prasugrel stopped 7 days prior to the procedure. Clopidogrel 5 days prior to the procedure. Cangrelor started 3 days prior to the procedure. And Cangrelor is stopped 1 to 6 hours after the procedure, prior to the surgery. After surgery, within 6 hours, the Cangrelor may be resumed and then later on shifted over to Clopidogrel. These are of various subgroups of risk of stent thrombosis, like those with stent failure, percutaneous coronary intervention 1 month ago, ACS more than 3 months, or within a period of 3 months, complex PCI, and those period it was BVS also. What they found, you can see, there was one death which occurred within 3 hours of discontinuation of Cangrelor infusion. MACE 4% in less than 48 hours, MI 4%, urgent TLR none, STL, the stent thrombosis 1, bleeding, life-threatening bleeding no. So perioperative bridging therapy with Cangrelor is a feasible approach for stented patients at high thrombotic risk and referred to surgery requiring DAP discontinuation, especially during the early phase of DAP following early phase of post-PCI period where DAP seems to be essential to prevent a stent thrombosis, mostly in patients with a complex stenting, left main bifurcation, multiple risk factors, single surviving coronaries, which was stented and all. So this is the protocol for bridging if required. Stop clopidogrel or prasugrel as indicated, 7 days for prasugrel, 5 days for clopidogrel. Start 3 days prior to the procedure, you start the Cangrelor, and 6 hours prior to the procedure, stop the Cangrelor, do the surgery. After 6 hours, you can give a loading dose of clopidogrel, and then we can use Cangrelor also. And reasonable to start Cangrelor for 3 to 4 days of bridging after prasugrel discontinuation, or 2 to 3 days for clopidogrel or ticagrelor discontinuation. And you can use even platelet function testing to help guide timing of the starting Cangrelor infusion. After the surgery, whatever be the bridging strategy, clopidogrel should be resumed with a loading dose as soon as oral administration is possible and the risk of severe bleeding is acceptable. That means the hemostasis is actuated as per the surgeon's point of view. If the use here, prasugrel and ticagrelor administration is mostly discouraged. And if you cannot give an oral agent, then still you can bridge with the Cangrelor. So when to use? It's mostly in acute coronary syndrome, STEMI. I prefer use when you cannot give an intravenous oral agent, like patient on ventilator, patient with cardiogenic shock, patient who is vomiting, patient who has been given a morphine, and all those patients where if you are going for a complex procedure like a left main occlusion, a left main disease in the acute coronary syndrome, where inhibition of platelet activity is essential during the early period, may not be for all cases. The guideline recommendation in 2017, a 2B recommendation with level of evidence A, Cangrelor may be considered in patients who have not received P2 vital receptor inhibitors. So let me conclude with this thing. An agent which was introduced in 2013 with the evidence and major trials at that time. Now, is it going to come back? Just the name what Phoenix says, is it going to resurrect from its own ashes? Thank you so much.
Thank you, Dr. Jabir, for that excellent presentation. You gave a nice overview of this molecule, which, as you correctly said, is not actually a very novel agent. It was there more than a decade ago, and with not very sound data in support of it. And with the Phoenix trial, as you very correctly said, it is kind of trying to make a comeback. And all of us know in our practice that despite, let us talk about a conscious patient who doesn't have vomiting, who's not on ventilator, shock, etc., so on and so forth, and you give this a loading dose of a drug like ticagrelor in the casualty, wheel the patient to the cath lab, we still have seen a sufficient number of patients where we are not happy about things going on. And we are forced to start an agent like GP2 inhibitor during the course of the procedure. All of us who are actively into cath lab practice will vouch for what I'm saying. There are cases every now and then where we find that the flow is not good, etc., so on and so forth. So with the background presentation by Dr. Jabir, we will move on to some clinical experience by a very experienced operator, Dr. Deepak Davidson, who will share his experience with this molecule. And then we will open up for questions in the chat box, as well as we can have a discussion among ourselves, including Dr. Jimmy as well. Over to Deepak, go ahead.
Good evening to all of you. Sir, am I audible?
Yeah,
Can you see my slides?
Yes.
Okay. Good evening to all of you. First of all, let me take this opportunity to thank Team MSN for having given me this opportunity. I'm also indeed privileged to share the screen with Natarajan sir, Jabir, as well as Jimmy. Over the next 20 minutes or so, I shall share with you a few cases, 5 cases, wherein Cangrelor was beneficial in these scenarios, just 2 cases, and in 3 other cases, probably I felt that it's got potential benefit in managing these particular situations. These are the 5 cases that I'm going to share with you. Are we all happy with the present day antiplatelets available with us in management of acute myocardial infarction? As we have heard from Jimmy, Natarajan sir, as well as Jabir, we know that all these patients who undergo a primary angioplasty, by the time we finish the primary angioplasty, we are still sure that majority of the platelets are not inhibited inside the cath lab. I start with the case history of a 76-year-old gentleman. He was a diabetic more than 45 years of duration. He had undergone renal transplant in the past. Now he has effort dyspnea, effort angina, for which he's undergone an angiography in the recent past. He has triple vessel disease. The right coronary artery was occluded. The circumflex has got moderate stenosis, and LED has got a critical stenosis. So he was not keen to undergo a bypass surgery, so was kept on medical management. He was just on aspirin and other guideline mediated medical management. He was not kept on dual antiplatelet therapy because of high risk of bleeding complications. So he presented to us with multiple episodes of breast angina with antival as well as infeval hypokinesia, and he was taken to the cath lab. And the plan was to just open up the left angiodescending artery because it was a critical stenosis. His creatinine also was mildly on the higher side. So our plan was to do very minimal intervention so that we could achieve a reasonable flow. He's an elderly man. We would want to prevent recurrent episodes of breast angina. So he was taken to the cath lab. He was loaded with clopidogrel. The procedure was done through the femoral approach 7 French guide catheter. We decided on reducing the contrast agent. And because there was significant amount of calcification, it was decided to have the procedure done with rotablation. That was 7 French guide catheter. The amount of calcium seen over there, that's the hemodynamic monitoring being done because we decided on low contrast PCA. And we also did an OCT with a saline flush, and you could see here that following the rotablation, you could see that there is multiple areas of almost 360-degree arc of calcification. We also went ahead with a cutting balloon, the Wolverine, and, that was a 3.3 millimeter Wolverine balloon that was dilated. And finally, you could see that there are multiple areas of calcium fractures seen at 5 o'clock, 7 o'clock position, at 1 o'clock position. So once we were able to break those calcium spicules and arc of calcium, we went ahead with stent implantation. We had wires in the diagonal, we had wire in the circumflex, and the stent was deployed. And we also rewired the diagonal vessel before we went ahead with post dilatation. You could see on the monitor that there is no significant ST depression till now. But once we completed this, he started developing angina, and that he also had breathlessness. It was more of breathlessness, not angina. On the monitor, we saw that there was significant amount of ST depression. So even though we wanted to have the procedure done with very minimal contrast, we thought that we'll do it. We are almost done with the procedure, but he continues to have angina. We did a contrast injection in the caudal view. You could see that there is no flow in the diagonal branch. There is slow flow inside the left antidistinct artery, and the RCA, which was filled from the left coronary, is not seen right now. So something has happened, and you could also see in the second half of the stent there is haziness over there. There is haziness in the distal half of the stented segment. So he was on heparin, he was on aspirin, he was given aspirin, he was given loading dose of clopidogrel in the casualty, and was taken up for the procedure. Finally, we had to dilate the diagonal branch. We had to do multiple balloon dilatations, and that was the final result. You could see we also had to initiate him tirofiban. Our intention was to reduce the bleeding complication. That was the reason why he was initiated on clopidogrel. But then ultimately we ended up, as Natarajan sir has just mentioned, we ended up having tirofiban for this particular patient, exposing him for a major bleeding complication. And you could see that at the end of the day, the flow was better, the diagonal was flowing, and you could also see that the ST segment on the monitor settled down. And that was the final OCT run. You could see here that in the upper image, you could see that in the second half, the distal half of the stent, you could see that those are the clots sitting over there. And that's a 3D image wherein you could see that there is significant amount of clot sitting in the distal half of the stent. So we know that he was on single antiplatelet. We initiated him on 600 milligrams of clopidogrel in the casualty, and by the time the procedure is over, he's got an interprocedural stent thrombosis, for which we had to initiate him on tirofiban, and he stabilized, and he was shifted to the ICU. Well, now regarding the incidence of interprocedural stent thrombosis, if you look at the Champion Phoenix trial, we could see here that the interprocedural stent thrombosis was 0.6% in the Cangrelor arm, and it was 1% in the clopidogrel arm, which means that you inhibit more of platelets. You try to nullify the angry platelets. Right from the beginning, the chances of interprocedural stent thrombosis could be significantly reduced. Now, what is the impact of interprocedural stent thrombosis? That's again alarming. You could see that this was again the data from the Champion Phoenix, which is evaluated by Dr. Greg Stone and was published. And they identified patients who had interprocedural stent thrombosis compared with the patients who did not have interprocedural stent thrombosis. You could see that the MACE, death, every events were significantly more in the patients who had interprocedural stent thrombosis at 48 hours as well as 30 days, which means that inhibiting the patients, nullifying the platelets right from the beginning of the procedure, the chance of interprocedural stent thrombosis could be significantly reduced, so that 30-day mortality, 30-day outcomes could be significantly better. Again, you could see here that patients who did not have interprocedural stent thrombosis at the end of 30 days, the mortality is significantly better. So one advantage of early inhibition of platelets with an intravenous agent would be something like this. You could have the chance of interprocedural stent thrombosis, clot formation inside the stent could be significantly reduced. And we also have data that in patients even with cardiogenic shock, the TIMI3 flow who were initiated on Cangrelor, they tend to have a better TIMI3 flow compared to patients who were not initiated on Cangrelor. And we also have data at this point of time, which means that patients who were initiated on Cangrelor following acute myocardial infarction, the cardiac MR has made out that the infarct size was less in the Cangrelor group compared to the placebo group. Well, that's the second case. He was an young doctor. He had undergone angioplasty to RC as well as circumflex artery few years ago. Now he presented to us with an infusion myocardial infarction. You could see in the first image that the circumflex artery is totally occluded and there is some amount of clot sitting there. So felt that that was the culprit lesion. You could also see that the left anti-descending artery is totally occluded. You could see that the right coronary, which has couple of stents in the right coronary artery. Again, that is significant stenosis in the right coronary artery. And in the right coronary angio, you could see that the distal LAD is faintly filling. So he has young chap, around 50 years, severe multivessel disease, and he has presented with infusion myocardial infarction. So what we did was we tried to reduce the angina by gently opening up the circumflex artery with the occluded circumflex artery was opened up with a 2 millimeter balloon, and we could achieve flow inside the vessel. And our plan was to send it for CABG at the earliest. And many times we know that surgeons are not keen to take these patients up for an early procedure. They would want to, because they were initiated on DAPT, they would always want to wait for at least 2-3 days prior to taking him for surgery. But this particular patient was taken up immediately the very next day for the surgical procedure, and he had some bleeding and he had to undergo re-exploration. So now we know that data says that patients who wait for more than 5 days after stopping DAPT, the primarily with clopidogrel, we even from the Plato trial, we know that if you really stop antiplatelets for 5 to 7 days, then the chances of re-exploration and post-CABG bleeding complications could be reduced. So one option that probably we have in these subset of patients would be probably if you're planning for a primary angioplasty, you could initiate definitely bolus of the initial loading dose of aspirin could be given in the casualty. He could be initiated on Cangrelor. Once the anatomy is seen, you know that there is no severe triple vessel disease, then probably you could initiate on the table, you could initiate ticagrelor so that there are at least a subset of patients who would need an early CABG in whom you're not exposing them for a dual antiplatelet therapy. That's the message from the second case. Well, that's my third case. This was a unfortunate 55-year-old gentleman. He had lymphoma in the past. He had chronic renal failure. He had undergone bypass surgery almost 5 years ago. Now he has recurrent angina. His left coronary as well as right coronary is totally occluded. Most of the vein grafts were occluded. His lima also was occluded, and only one graft to the diagonal branch was patent. That's a vein graft that was connected to the diagonal branch, which is supplying collaterals to the most of the vessels inside the heart. We could also see the septal branch flow coming through the septal branch going to the right coronary artery, and you could also see that the lima is occluded immediately beyond the anastomotic. The LAD is occluded beyond the anastomotic site of the lima. So we had to do something for this particular patient. He had significant LV dysfunction. He had presented with recurrent heart failure, and so he was taken up for angioplasty to the CT of the right coronary artery as well as the left anterior-descending artery. That was the CT of the right coronary artery, which was recanalized, and that's the left anterior-descending artery. You could see that in the first image, the immediately beyond the anastomotic side, the left anterior-descending artery is occluded. We could open up this particular vessel through the lima. The LAD also was opened up. However, something unfortunate happened. We ended up having dissection of the left internal mammary artery during the angioplasty of the left anterior-descending artery. We didn't want to inject much into the once we identified that there was dissection, we didn't want to inject much of contrast into the vessel. So we went ahead with an IVUS evaluation, identified the extent of dissection inside the lima, and we had to ultimately ended up having 2 stents deployed in the lima, that is right from the mid lima back into the origin of the lima, and finally we were able to achieve good flow in the LAD. Now this patient did well for the next 2 weeks. 2 weeks later, he had bleeding PR, and when he was evaluated, he was very unfortunate, multiple malignancies, CKD, CABG. Just 5 years following CABG, he had all the grafts occluded except one. And 2 weeks following this procedure with multiple stents inside the coronary, he was diagnosed to have CA rectum. It was a major. We wanted him to wait for a while, but then the family members, the surgeons, everyone wanted to have the procedure done. So at the end of 4 weeks, he underwent surgery after stopping the antiplatelet agents. He was having multiple stents in Lima LAD as well as the right coronary artery with LV dysfunction. The perfect recipe for a stent thrombosis with LV dysfunction, all those things. We had to stop the antiplatelet agents, and the day after the surgery, he had a cardiac arrest, and he could not be resuscitated from that. Now, this was an unfortunate event. Now, that brings us to the question what Jabir has mentioned. Could we bridge him? Could we bridge him so that the chances of reducing the platelet action till the surgery is over could be significantly reduced? So that again, we have data in favor of this bridging. That is, when you stop clopidogrel, when you stop ticagrelor, when you stop prasugrel, you need to wait for 5 to 7 days. So initial 2 to 3 days, probably you will invariably have significant platelet inhibition by whatever aspirin, whatever clopidogrel or the other antiplatelet agents. But then after 2 to 3 days, probably you could, for the next 2 days or next 3 days prior to the surgery, you could bridge them with the IV Cangrelor. But then keep in mind that the dosage of IV Cangrelor for this particular infusion, 2 days or 3 days, we have data up to 5 days of infusion of IV Cangrelor. So this could be infused till the morning of surgery, the day of surgery being done. So could stop Cangrelor in the early in the morning, wait for 5 to 6 hours, do the surgery, restart them on Cangrelor, and then initiate them on clopidogrel. Now that is what is recommended, so that you are totally not exposing these stents. You're not to a chance of developing thrombosis. You are at least minimally protecting your stents, so that till the surgery is done, till 5 hours prior to surgery, you're infusing that, and immediately following surgery. So this could be a potential benefit. We do once in a while come across these sort of high risk patients who needs to undergo some sort of emergency surgery, wherein an early surgery wherein you wouldn't want to stop your antiplatelet agents for 5 to 7 days. So that is one particular scenario wherein this particular agent is going to be of great benefit. That is bridging when you stop the antiplatelet therapy for a major surgery. Well, now, this is the fourth case scenario. This was managed in a hospital with intravenous Cangrelor. He was an elderly man, inferior MI. While traveling the train, he got down immediately. He was shifted to the hospital. In the casualty, he had multiple episodes of VT, VF, promptly cardioverted, not intubated. Even in the cath lab, he had multiple episodes of ventricular tachycardia, ventricular fibrillation. He had autonomic symptoms. He had vomiting. So whatever loading ticagrelor and aspirin was given, it's all gone. It was all he puked out. So ultimately, we had to take him up for the procedure without any antiplatelet agents on board. So that was the reason why we initiated him on Cangrelor. Once the procedure was over, we again initiated, and once the vomiting, everything settled down again, restarted him on aspirin as well as ticagrelor. But then during the procedure, we had a protected procedure just because we could initiate him on Cangrelor in a cath lab. We have only very few cases wherein we have done the procedure with Cangrelor. This was one high risk. Next one, yet another high risk case I'll be presenting to you. But the other few cases are all low risk ones, because initially we wanted to have a confidence in this particular molecule. These are the two high risk patients that I'm going to present now. So he presented with an inferior MI, multiple episodes of vomiting, VT, VF, taken to the cath lab, 6 French guide catheter through the radial approach. We dilated the lesion, we did thrombosuction, and there was significant amount of clots inside the circumflex artery. As seen in the second image, in spite of doing thrombosuction, you could see that the flow inside the vessel is TME2. You could also see that at the end of the cine, the patient is again developing VT and VF, and you could also see that there is a hazy looking ostial LED lesion, which is almost 70% or so, which we wanted to have which we wanted to stage it at a different point of time, because the patient was totally unstable. So finally, we went ahead with stent implantation, and he had again, during the stent implantation, post-stent implantation, he had severe slow flow. We had to have the aspiration catheter inside the vessel, give intracoronary nicorandin nitroprusside, and even a lot of adrenaline was given inside the circumflex artery. You could see that the flow was better. It was almost TME3, but the microvasculature is not seen at all. And finally, we stabilized the patient over the next one hour. He stabilized on the table. The VT, VF, everything settled down. And once that was done, we thought that anyway, we need to stage this particular patient. for a left main to LED angioplasty. So prior to that, because he was stable, the left main also was looking very huge. It was looking almost 6 millimeter on the table. So I thought that I'll just have an evaluation of the size of the left main by IVUS, as well as the proximal LED was looking more than 4 millimeter in size. So I thought I'll take the wire inside the left anterior descending artery and just take an IVUS run so that I can just assess the size of the LED, size of the left main. You could see in this particular image, the size of the left main is looking so huge. So wanted to arrange for a proper stent for a angioplasty at a later point of time. So that is the reason why once he stabilized, now we could see that in this image, the circumflex flow is much better than what it was. So finally, we did an IVUS evaluation, and this was how the IVUS looked like. If you could concentrate on the second image, don't have to go through the entire run. This is the second image. You could see that that's the flap inside the left main. So there was a lesion in the LED which was actually extending into the left main, and there was a ulcered flap. It was an ulcerated flap which was actually it was an ulcerated flap inside the left main. And you can also see that the left main size is almost 7 millimeter in size. Well, so we decided that we wouldn't leave that flap for another day. And by the time the patient was almost settled down, he was on Cangrelor. So what we did was we had a 5 millimeter stent with us. That was an Onyx to 5 into 26. The LED was 5 millimeter in size based on IVUS. The left main was 7 millimeter in size. We removed a 6 French guide catheter through the radial approach. We engaged the left main with a 7 French guide catheter, and then it was stented with a 5 millimeter stent from the left main ostium into the LED. And we post-dilated with a 6 millimeter balloon. That is a post-dilatation of the proximal optimization with a 6 millimeter balloon. That's the proximal optimization. You could also see that that's a Boston balloon. That's an emerged balloon. You could see that even in the second image, you could see that the deflated balloon, 6 millimeter balloon, can move easily in and out of the left main. Just to highlight that it's a reasonably good balloon, and that is the final result. So, however, we also did an IVUS evaluation of the mid LED as well as the stented segment. We made out that there was under expansion at the mouth of the left anterior descending artery. So we again post-dilated the LED ostium with a 5 millimeter balloon, and that was the final result. Now, this particular patient settled down. Then the flow in the circumflex artery was good. The left main was stented. The flow in LED also was good. So at the back of the mind, we were happy that we've initiated him on Cangrelor, at least because whatever loading, whatever DAPT he's received, it's all gone out during his vomiting episode. So finally, we were happy. We continued the infusion for 2 hours, and then we again reloaded him with aspirin as well as ticagrelor. So just to highlight the fact that in these subset of patients who are very sick in the casualty, there is definitely a role for this particular. These are the subset of patients who would be grossly benefited. The sickest one, the ones with cardiogenic shock, somebody who's on mechanical ventilation, active vomiting, heavy sedation, wherein the absorption from the GI tract would be significantly less. These are the subset of patients who would be benefited grossly, hugely with intravenous Cangrelor. And that's my last case, and I'll stop with that. This was again a 50s, somebody who is in the early 50s. He had undergone an angioplasty to the ostial LED exactly 1 year ago. He had a urology issue, and he had to undergo a procedure related to urology, and we were happy to stop the dual antiplatelet therapy because it was almost 1 year following the stent implantation to the left anterior descending artery. He was admitted. He underwent the urology procedure, and once the procedure was over by noon, and he was shifted to the recovery room. And almost 2 hours later, inside the recovery room, he did not have breathlessness. He did not have angina. He just had a cardiac arrest. So nobody knew what exactly was happening. Immediately, the anesthetists, everyone, they immediately started CPR for this particular patient, and we were also called in, and we were not sure what exactly was happening. Nothing, no rhythm was there on the monitor, no QRS complex, continuous ventricular fibrillation. We even felt that it was total asystole. Echocardiographically, the heart was not moving at all, no movement of the heart at all. Mitral valve, aortic valve, nothing is moving. Almost 45 minutes CPR resuscitation was done. In spite of that, nothing, no spontaneous circulation did not return, and so we decided that probably because he was just 52 years old, we thought that we'll at least have coronary anatomy evaluated, take him to the cath lab. With the CPR being continued, he was taken to the cath lab. And before we started doing angiography, we wanted to support a circulation. So percutaneous implantation of ECMO was done. That was you could see here that that's the 25 French. That's a 25 French venous sheath that was positioned inside the right atrium superior vena cava, and a 21 French sheath was positioned inside the left femoral arterial sheath, so that the blood could be returned into the arterial system. So we initiated ECMO circulation, and then we went ahead with an angiography through the right femoral approach. That was the angiography. Right coronary was reasonable. The cardiac contractility was not significantly there at all, and there's a huge clot inside the left main bifurcation. You can also see that stent is sitting at the right at the ostium of the LAD. I think I'll go a bit more faster. We wired the vessel. We did multiple thrombosuction. It was like learning angioplasty. The heart was really not contracting at all. It was working on a still model. Like we wired the LAD, we wired the huge ramus branch. Every time we aspirate, the clot would move from one side to the other side, in spite of it being a very fresh clot. It would move from one vessel to the other vessel. So finally, we had to do balloon dilatations on both the vessels, but still nothing seems to happen. So we decided that even we felt that the stent in the LAD was a bit underexpanded. So we had to go ahead with further dilatation of the stent in the LAD with no cardiac contractility. You could see contrast sitting at the aortic cusp. It is not moving at all. We stented the ramus. We went ahead with the bifurcation stenting of the left main to LAD, and those were the final results. The flow in the LAD, the flow in the circumflex, and the heart is not contracting at all. And with the ECMO, he was also initiated on intravenous balloon pump, and he was shifted to the ICU. So that was a sort of flow that we could achieve at the end of the procedure on ECMO, on IABP, and here no arterial pressure tracing on the intravenous balloon monitor. So he was shifted to the ICU. We waited for a few hours, and slowly the heart started contracting. And next day, that is a sort of echocardiogram. You could see there is huge amount of edema in the interventricular septum, and that is finally he survived. The intraventricular balloon was removed, the ECMO was removed, and that is how it was on follow-up. The LV function, even though it's less than 30%, he's still alive. Now we felt that we were not sure whether what should be the next line of management once ECMO was inserted. What sort of DAPT should be given for this particular patient? This happened just 1.5 months ago, so we had Cangrelor on shelf. So we decided that we would definitely give him aspirin. We would start him on Cangrelor. Once the procedure is over, we initiated him on clopidogrel, because we know most of our urologists, they wouldn't want us to give ticagrelor for any of their patients who undergo procedures. So because even we felt that the bleeding complications following the urology procedure is going to be very high, so we initiated him on aspirin and clopidogrel. Clopidogrel was initiated once the procedure was over, and he was very fortunate that he survived. So again, the usage of Cangrelor in cardiogenic shock. This is from Massachusetts, from Dr. Butt's center. They made out that in patients with cardiogenic shock, wherein the Cangrelor was given, the mortality was just less, almost 13% out of 38 patients, and they had a better outcome. Again, if you look at the SHOCK 2 trial registry, patients who received Cangrelor, they had a better TIMI flow. TIMI grade flow was better in the subset of patients who had received Cangrelor with cardiogenic shock. So again, it goes to say that these very critical patients, the subset of patients who are very critically ill, probably wherein the absorption of the aspirin or ticagrelor or clopidogrel has not happened from the gastrointestinal tract. These are the subset of patients who are going to be maximally benefited with the use of intravenous Cangrelor. I once again thank Team MSN for the opportunity given. Thank you so much.
Thank you, Dr. Deepak, for sharing such exciting cases. You very smartly showed 3 cases where there is a perceived need of a better antiplatelet agent by the limitations of the contemporary antiplatelets before Cangrelor was relaunched in the market. So it was a nice exposition of. I also wanted to ask you the same question in case you had not showed the first 3 cases. In contemporary practice, with ticagrelor being the most commonly used second antiplatelet in addition to aspirin, in the emergency room itself, in most of our patients who come to the cath lab, do you really see the need? I personally feel there is a need in a lot of patients where you're not happy. Somehow the flow is not good. You're forced to give GP2 antagonist and there is a risk of bleeding. So there is a definite role of this molecule for instantaneous antiplatelet action. So the last 2-3 cases that you showed where this drug made a difference made it a very exciting presentation. And we have some very good questions in the chat box. We'll go through one by one. I will read out the questions and I'll invite answers from any one of the three of you. Dr. Abhijit, he wants to know, is this a molecule of choice in cardiogenic shock patients? So I will answer this question. See, the current guidelines very clearly say that this is a drug which should be considered in all forms of percutaneous interventions, whether it is stable angina, unstable angina, non-ST elevation MI, ST elevation MI, where oral DAPT is not being able to be provided. So when oral drugs are not provided, for example, a patient with intubation, patient has vomiting, etc., where you are doubtful about the second agent reaching the circulation, that is when this agent should be used. That way, a lot of registry data have clearly shown that people have gone beyond what the guidelines have suggested. In that category, cardiogenic shock, post-cardiac arrest survivors, and ST elevation myocardial infarction as such, even if the patient is stable, operators have a lower threshold to consider Cangrelor. So ST elevation myocardial infarction, cardiac arrest, cardiogenic shock patients, patients on ventilator, where you are not able to load them with oral drugs, where you are doubtful about the efficacy of orally given drugs, is a class 1 situation wherein you should consider this molecule. It will be the answer to that question. The next question, I will pose it to Dr. Deepak. Coronary.
Sir, 1 second, sir. Sir, regarding the same question, even in the SHOCK 2 registry, the subgroup analysis, they made out, as I've showed in the last slide, they made out that the TIMI grade flow was better in the group of patients who received Cangrelor compared to the placebo group. And also there were, as you mentioned, there are also some registry data that says that the LV function was better. The myocardial recovery was better in the group of patients who early received Cangrelor compared to no Cangrelor group.
That stands to reason, because the more effective the antiplatelet action is, better the myocardial perfusion is. You may have a great epicardial coronary flow, but at the end of the day, you need myocardial perfusion, as used to be shown by the traditional myocardial blush scoring, etc. Those things intuitively make sense that better the antiplatelet action, better will be the recovery of myocardial function. Absolutely correct. So we move on to the next question. Coronary angiography revealed ostial obstruction of RCA, suspecting hypercoagulable state of these patients. Please suggest. Dr. Vishal from Ahmedabad is asking the question. Deepak, you want to answer that question? You're also seeing the chat box, right?
Yes, sir. Yes, sir. I just saw that. Coronary angiography revealed ostial obstruction of the right coronary artery, suspecting hypercoagulable state for this particular. Please suggest. Sir, I think it's probably we need to evaluate these subset of patients when you suspect huge normal-looking coronaries with just huge large clots inside the coronary artery. Probably one needs to, at the end of the day, evaluate whether he's got prothrombotic state. That should be evaluated. But then when the patient is inside the cath lab, our primary aim is managing that particular huge thrombus burden inside the right coronary artery. And at this point of time, probably based on whatever data we have, that's the way to go. Start them, load them with aspirin and then ticagrelor, and probably initiate them on Cangrelor.
So you're making a point that more the thrombus burden, the lower will be your threshold to consider this molecule, in preference to the conventional orally administered DAPT, isn't it?
True, sir. True, sir.
That's a good point that you have made.
Sir, can I just continue with that? One more point. Yes. Sir, regarding these are the subset of patients whom halfway through the procedure, maybe our experience is very limited, but then halfway through the procedure, probably you might feel that even Cangrelor may not be working. Should we add a glycoprotein 2b3 receptor blocker in these subset of patients? But I'm not sure. That's a question there in the chat box, whether you could add tirofiban in these subset of patients who have heavy thrombus burden. But when we look at the data, even the Champion Phoenix trial, almost 3.5% of patients, they had received glycoprotein 2b be the receptor blocker. But then at the end of the day, when subgroup analysis was done, they had more of bleeding complications compared to patients who did not have glycoprotein 2b3 receptor blocker. But I think it's we need to decide on that on the table. If we find that there is huge thrombotic burden at the end of they're having a slow flow, probably one could initiate them on tirofiban also. I'm not very sure about that, but I don't think data supports this.
That question was asked by Dr. Abhishek Mahatma from Jaipur. I think there is no data to confidently tell you that you can use both tirofiban and Cangrelor. And I hope most of our PAMI patients won't have that kind of a very bad situation. The way Cangrelor acts and it's instantaneous, it should do the job most of the time. And you may probably you can supplement it with thrombus aspiration and things like that, and have the highest threshold to combine glycoprotein antagonist with a powerful agent like Cangrelor. And so that answers that question. So to Dr. Jabir, Dr. Barua from Guwahati has asked you the question, can Cangrelor can be used as an intracoronary agent? Dr. Jabir?
No data on intracoronary use, because here also there is no need to use it intracoronary. Here it's a very rapid onset of action, which is proven in all the pharmacodynamic studies that it acts in 2 minutes. So there is no additional benefit of using it in intracoronary. The thing is that there are certain situations when we use with a huge thrombus burden, we go inside with a clear catheter into the thrombus and instill glycoprotein 2b3 receptor antagonist and all. We have data on that, but we don't have data on the intracoronary use of this particular agent.
I agree with you. So probably there is no incremental benefit. Intravenous Cangrelor will do the job as much as the perceived need for intracoronary administration. Dr. Jimmy, I'll just pass on the question which Dr. Praveen from Coimbatore has asked us. If failed thrombolysis by outside, but if you do a rescue angioplasty in that patient, let's say you have to do it very early. Somebody undergoes thrombolysis, there is ST elevation continuing, the patient is hemodynamically unstable, you are shifting the patient within, let's say, 2 hours after the thrombolysis. What's the good role Cangrelor in this particular situation? Is it safe to give in post-thrombolysis patient? What is the way forward? Jimmy, you want to answer that question?
So like post-thrombolysis always is a very risky and almost state where you've got a high chance of bleeding anyway. So most of these cases, even we may take it with a pinch of salt for an emergency angioplasty, telling all the high risk. At the same time, all these patients will be loaded with high dose of oral antiplatelets from outside, or at the same time, maybe I've given an extra dose of GP inhibitors also along with that. So always it's a high risk of bleeding stage, and over that we are going to give a patient with, or I would definitely see the anatomy first, then take on a decision, but definitely keep it as a lower threshold for giving this medication.
As an add-on to whatever you said, one should understand that Cangrelor is not more potent than ticagrelor. It is only that the action is instantaneous because you are directly giving it parenterally. That is the biggest advantage. You are not sure about the effect of the drug that you are given orally. So it is in no way more potent. So that way, to answer Dr. Praveen's question, beyond what Dr. Jimmy has very correctly said, I'll ask the question. Somebody comes to the post-thrombolysis and you're doing a rescue angioplasty. All of us have been using dual antiplatelet. We have loaded these patients with ticagrelor, etc., with the hope that the ticagrelor works. So there is no reason to shy away from Cangrelor in this particular subset for the fear of bleeding, because you want instantaneous antiplatelet action, more so in a patient who was not opened up despite thrombolysis. So it may not be unsafe to give. The next question.
Natarajan, let me, in that particular situation, it all depends upon the time, as you rightly pointed out, it's a speed of action. But the CANDIC study has shown that even if it is a crushed ticagrelor, within 2 hours or by 1 hour or 1.5 hours, the antiplatelet inhibition of antiplatelet activity is not adequate with the use of ticagrelor. So it is time. If you are taking up for rescue angioplasty within 2 hours in a cardiogenic shock, I must use this drug. But if it is after 4 hours or 5 hours of loading of ticagrelor, then it may not be of much use.
Natarajan, I would just like already these patients will be loaded with antiplatelets. So all the receptors are already engaged with this antiplatelets. So like in Jabir's talk also, so we're saying about like once these receptors are already engaged, will there be a chance of getting this Cangrelor into action, or will there be a stronger action?
That patient, if the orally given ticagrelor, let's say, has done its job by occupying all those receptors, the job is already done. Cangrelor may not give any additive benefit, but no harm done. But there's no way of proving whether the receptors are being engaged by the orally administered ticagrelor. In such a high-risk patient, giving Cangrelor is of no, it doesn't do any harm, but there is always a potential benefit when you are uncertain about the oral action of the drug. And as Jabir very correctly said, longer the duration you feel that the action will be there, shorter the duration, there is definitely a doubt about the efficacy of the orally administered drug. So shorter the duration, definitely Cangrelor scores over. That's what I would say. And next question I will ask Dr. Deepak to answer. Primary PCI already loaded with ticagrelor. Can we give Cangrelor? Obviously, the answer is yes, isn't it?
Yes, the same data Dr. Jabir has presented just now, CANTIC trial. That is, you load them with ticagrelor. Still, you compare one group who's been loaded with ticagrelor, which is crushed. The other group received crushed ticagrelor plus Cangrelor. If you look at the platelet reactivity drops to immediately almost 0% in the group who was given Cangrelor with ticagrelor, crushed ticagrelor. But then it took almost 2 hours for the subset of patients who received just ticagrelor for the platelet reactivity to be suppressed.
So there is no problem in giving Cangrelor to a patient who has already received ticagrelor. I will just ask you the brief extra question beyond what Dr. Gokhale from Bhopal has asked. If somebody has received 600 milligrams of clopidogrel, let's say 1 hour before you shifted the patient to the cath lab, what will be your approach? Can you still give Cangrelor?
So we know at this point of time that clopidogrel, it takes at least 4 hours for the platelets to be inhibited, at least 4 to 6 hours. So when we have a high risk patient, somebody who's got an extensive anti-wall myocardial infarction, thrombus burden, probably it's definitely worth adding Cangrelor in this subset of patients, hoping that by the time the clopidogrel exerts its action, probably Cangrelor would have helped him. But then one should also keep in mind that if clopidogrel was given half an hour or 1 hour prior to Cangrelor, at the end of the procedure, it's always good to reload them also. So that once the receptor occupancy is gone from Cangrelor, again, you are once again loading them with clopidogrel. So that also would be a wise option to do.
That is exactly what I wanted you to answer to that particular question. And Dr. Jabir showed that interesting animation slides wherein this active metabolite of clopidogrel and prasugrel have a shorter half-life. So by the time the Cangrelor effect weans off, the clopidogrel, the active metabolite of clopidogrel also would have been gone from the system. And that is the merit of reloading, which you so beautifully pointed out. So I was very happy to listen to the answer that Deepak provided to that question, which was asked in the chat box. How long Cangrelor can be given as bridge therapy? That was partially answered in Dr. Jabir's talk. Dr. Jabir, you want to answer that question? You showed.
Actually, that depends upon which antiplatelet you were using. If it is prasugrel, you stop it 7 days prior to the procedure. If it is clopidogrel, 5 days prior to the procedure, and 3 days prior to the procedure. By that time, almost the platelet activity will come down. The platelet inhibition will come down. You start on Cangrelor. You can give it up to almost 6 hours prior to the procedure, and then you do the procedure. And once the hemostasis is active, reload with the antiplatelet agent, preferably clopidogrel. If it takes a long time for the oral therapy to resume, at the same time, the patient has achieved hemostasis. It all depends with after discussion with the surgeon. Then you can consider restarting the IV Cangrelor till the patient is able to resume oral drugs. So for some reason, they have given up to 9 days, 12 days infusion.
The cost escalates by doing that.
But this is a very good point, Natarajan. Like bridging therapy is something which we were not seeing in post-PCI patients, especially when you have a complex angioplasty or when you have multiple long stents. And even like what Deepak sir was showing the last case, after 1 year of dual antiplatelets, he just stopped it for 3 to 5 days for a urology procedure. And suddenly the entire thing shuts down. So thing is like very late stent thrombosis are something which we are not actually giving much importance of it. At least thing is like when you have a drug like this, Just like when you give for a prosthetic valve, apparent bridging, this is also a wonderful drug, which would be the future for bridging of most of the procedures when you have a complex procedure.
A very good point that you made out, Dr. Jimmy. I was about to ask one of you the same question. In today's time and age, the properly done angioplasty with optimum results, let's say optimized with imaging also, perfect expansion, current generation drug-eluting stents, I won't name them. So in that kind of a result, how confident will Dr. Deepak be to stop the second antiplatelet for a non-cardiac surgery? I'm not talking about the first 4 weeks. The first 4 weeks, we know it's a vulnerable period. So definitely there is a role for Cangrelor. Let's say 3 months down the line, for the angioplasty, the way you have demonstrated in your own cases, Dr. Deepak, will you be happy to stop the second antiplatelet drug, let's say 3 months down the line for a non-cardiac surgery without the need for bridging?
Yes, sir, certainly, sir. Based on whatever data we have, even for patients who need to undergo some sort of hernia repairs and all, at the end of 3 months, once you've done a good procedure with the contemporary stents with data, we do have data with sirolimus as well as everolimus eluting stent, 28 days DAPT data. It's presently available at this point of time. So based on these data, if it's not a very complex stenting, like a complex bifurcation or a left main or multiple stents, I would definitely be happy. I would definitely be happy to stop at the end of 3 months and send it for some sort of dental extraction or surgery, which would be required for him. But then when it comes to a complex stent implantation, probably I wouldn't be happy because data is not really available for us to stop early DAPT.
I fully agree with you. I would be very hesitant to stop the second drug even for up to 1 year. More complex the intervention, at least for a year, we are quite happy to continue the second antiplatelet, and we are a little worried to stop the second antiplatelet drug, left main, bifurcations, multiple stents, triple vessel stenting. That's most of the angioplasty that's being done by most of us in today's time and age. So the more complex the procedure, the longer you would like to have, at least for 6 months or so, I'll be more happy to continue the second antiplatelet, and I will consider the Cangrelor kind of drugs, at least for the first 6 months, even for a properly done angioplasty. So that actually brings us to the end of most of the questions which came in the chat box. So I thoroughly enjoyed it.
I think one question from Dr. Mahesh from Parimala. Did you see the last question? One more question.
I didn't see. Yeah. This question we have already answered, right?
Okay, a clopidogrel loaded patient from elsewhere.
Yeah. So the answer to that question which Dr. Mahesh has posted in the chat box is yes, we can. Because no harm done by giving Cangrelor to a patient with preloaded clopidogrel. The only thing is, as Dr. Deepak and Dr. Jabir have clearly demonstrated during the course of the presentation, you should reload them at the end of the Cangrelor infusion. Because whatever clopidogrel you gave, the active metabolite may not be in the system. There can be rebound thrombosis at the end of the procedure. So you should reload them. That's what the answer should. You agree with me, Dr. Jabir and Dr. Deepak?
Yes, I fully agree with you. Either you reload with the clopidogrel or I may shift over to ticagrelor and give the ticagrelor during the procedure itself.
Anyway, most of us have forgotten clopidogrel, like we have forgotten the good old ticlopidin which we gave during days. So when something comes new, we forget the previous good friends. That has been the bane of all of us.
The ticlopidin, it's thrombocytopenia, diarrhea, and the rashes.
Neutropenia. We gave a combination.
Neutropenia, diarrhea, and rash.
Combination of ticlopidin, aspirin, and vitamin K antagonist in the year 1996. And we did a workshop of about 3 angioplasties, and we were unfortunately on duty that night. We had to literally stand on the patient's groin. And we did multiple blood transfusions. From those times, we have really made significant progress in the way we treat these patients in terms of antiplatelet without the need for heparin. Somebody in the chat box asked a question, is there a dose required if heparin is given along with Cangrelor? The answer is no, right? Heparin can be given the way it is usually given, and Cangrelor is an add-on to heparin. So you don't have to be worried about heparin and Cangrelor as an interaction. Yeah. So I thank MSN once again for the wonderful session that we have had. And I thank I thank Dr. Jimmy, the co-moderator for this session. An excellent talk by Dr. Jabir, and nice cases as always from Dr. Deepak, my good friend. And over to Nitin for your concluding remarks.
Thank you so much, sir. On behalf of MSN Labs Private Limited, my heartfelt thanks, gratitude, and respect to, first of all, Natarajan, sir, for sparing your precious time, sir. And at the same time, I would like to thank Dr. Deepak, Davidson, sir, and Dr. Jabir, sir, for your excellent presentation. And Dr. Jimmy, sir, also for clearing the doubts on this subject as a whole. And my sincere thanks to all of you for clearing the concepts of novel antiplatelet agents and especially the uses of Cangrelor in these very patients. And my special thanks to all the audience who has been today with us and clearing the doubts of all the cardiologists with your relevant questions to the audience. Just with a small presentation, just I would like to say thanks to all of you, sir, that we may be we may be the young player, but our drive and enthusiasm are the best in associating with all of you with the newer molecules which we are bringing in the industry, sir. So thanks a lot for sparing your precious time. We would like to have much more these kind of sessions with all of you, sir. Thank you so much. Good night, sir.
Good night. Good night.
Good night. Natarajan, sir, good evening. Jabir.
Good evening. അവിടെ എങ്ങനെയുണ്ട്? തകർക്ക് വന്നോ?
ഒന്നുമില്ല. Post COVID. Last 2-3 weeks relaxation ആയിരുന്നു. ഇപ്പൊ വീണ്ടും.
ഇവിടെ പഴയതുപോലെ. But only thing is all the cases are very complex.
Very true.
എല്ലാ ഈ CABG deny the patients renal failure. ഇത് രണ്ടുമാണ് നമ്മളുടെ bread and butter ഇപ്പം.
അതെ, ഇന്ന് ഈ ഗൈഡ് എക്സ്റ്റൻഷൻ കത്തീഡ്രലുകാർ വന്നപ്പം ഇപ്പൊ ഓൾമോസ്റ്റ് എല്ലാ കേസിനും യൂണിക് ഗൈഡ് എക്സ്റ്റൻഷൻ, ഓൾമോസ്റ്റ് എവറി കേസ്.
എല്ലാ കേസിനും
എക്സെപ്റ്റ് പ്രൈമറി ആൻജിയോപ്ലാസ്റ്റി കുറച്ച് സിമ്പിൾ ലീഷൻസ് കാണാറുണ്ട്. അതർവൈസ് എല്ലാം ഡിഫിക്കൽട്ട്.
ഓക്കെ, ശരി ദീപക്.
ശരി ജാബിർ, ബൈ.